Now, I thank you for that background, and that helps me better understand your passion for this. So now I really appreciate you're coming from it from the personal and from the scientific side.
Yes.
Yeah, just brief background for me. I'm originally from Canada. And I did my fellowship and at MD Anderson Cancer Center, and I went through the faculty ranks there and became a department chair. I built a new department of early phase studies that really became the largest of its type in the world. I moved to UCSD about 8 years ago, and to build the precision medicine program. And I'm also the chief medical officer for the WIN Consortium for Precision Medicine. So that's like my background. I'm passionate about clinical trials and precision medicine, basically. So, so thank you again for having me come on. I really appreciate it.
Yeah, you're very welcome. I follow you, so I can see all your tweets, and I kind of know, different things that you post. So that has been like, Twitter has been great. Like, I only joined like 2 years ago, but there is so much science that goes on Twitter that I use it exclusively for that. And it's
I do too. I think the medical Twitter, if you stay away from the politics, is medical Twitter, I think, really brings people together. And really, I go on Twitter and I know, oh, this was just published. It's really like a good, fast way to see where you are scientifically. And also, it's done an incredible job of bringing people together from really all over the country. So
yes.
So let me know when we should get started. I think it's about noon, but just let me know what you want me to do.
Yeah, we can wait for like 1 or 2 more minutes. I think people are starting to join.
Are you going to do an introduction or this not?
Yes.
You are?
Yeah.
Okay.
I'll just say a few minutes and I'll probably read, your titles. And then you can start, you can add on to that and introduce more and then start the talk.
Absolutely.
If that's okay.
That's fine. How do you pronounce your name, just to be sure I've got it right?
Yeah. Manju.
Hello?
So you say all the letters. People are, hello?
Can you do it again? You froze. Sorry.
Oh, sorry. Manju is how you say my name.
Manju George.
Manju George. You say the J.
Manju George. Got it.
Yes. Okay. Yeah. People are always confused when they see the J, whether they should say it or not. Yeah. Another 1 minute and then we can start. So maybe while we wait, so when you start a trial, like, is it like, do you come up with the idea and then go look for different partners for the drugs, or do the drug companies come to you first, or is it a mix of both?
It's a mix of both. Okay. And what I've tried to do both at MD Anderson and at UCSD is to have a master study that's a precision medicine study that navigates patients to off-label drug use or to secondary clinical trials. So I'm very firmly biomarker based. We try to match patients with drugs, and we've done that increasingly now. Drug companies do that, but we did it at MD Anderson before the drug companies did it. We did it for them. And And at UCSD, we do the same thing. We try to match. My firm belief is that patients do better if there's biologic markers, genomics, it can be transcriptomics or immune markers, and then you match them to the right drugs. This really weighs the dice in their favor.
Yeah. Mhm, mhm, mhm. Okay, I think let's start. So, hello everyone. I'm Manju George, the Scientific Director of COLONTOWN. And today we are very honored to have Dr. Kurzrock with us today. She is the Director of the Center for Personalized Cancer Therapy and Director, Rare Tumor Clinic, and a leader of experimental therapeutics and Associate Director of Clinical Science at UCSD and Chief Medical Officer of the WIN Consortium for Precision Medicine. Dr. Kurzrock, I'm so happy to have you with us.
Well, thank you for inviting me, and it's a pleasure to speak to everybody. And what I'm going to talk about is the lessons from precision medicine and early phase trials and how that pertains to colorectal cancer therapy. And these are my disclosures. So there's just a little bit more background about me. I've been at UCSD for a little bit over 8 years. I do several things there, but the thing that I'm really passionate about is the Center for Personalized Cancer Therapy, where we have really instituted, I think, a very strong precision medicine program. Before UCSD, I was at MD Anderson Cancer Center in Houston, and I was the founder and chair of a department, a new department of early phase clinical trials. We exclusively did phase 1 clinical trials. And this department really grew to be the largest of its type probably in the world. We were involved in multiple clinical trials and many drugs that went on to FDA approval. So the take-home points, I want to start with them. And my main point is about getting the right drug to the right patient at the right time and how we know what is the right drug or the right drugs for those patients. And so this goes back to understanding how cancer works. And the first thing I want to say is at the genomic level, every tumor that is metastatic is both unique and very complicated. I live in California now, but I grew up in Canada. And so I know a little bit about snowflakes. And I want to compare tumors to snowflakes in that when you look at snowflakes, each one has a distinct crystal structure, and each one is very complicated. And that's what we believe that tumors are like now that we have next generation sequencing. And this means that metastatic disease requires customized individual combination treatments, not single agents for the most part. The pillars of precision medicine are genomics and immunotherapy, and people often think of them separately, but we think of them as a couple that are married to each other. And immunotherapy may be best suited for the most complicated tumors, and we'll get into why that is. So let's start with talking about phase 1 studies. And phase 1 studies are clinical trials where we're doing something for the first time. We may be bringing a drug first in human. It's been studied in animals, and now we're doing a clinical trial in patients. Or we may be bringing a completely new combination of drugs that have never been used before. So there are some misconceptions, and I want to go through them because these were concepts that were true maybe 20 years ago. But they are no longer true now. And the first misconception is that phase 1 drugs are ineffective at low doses because for safety reasons, we start at low doses and we go to higher doses. But we have published on this, and there are drugs that may be less effective at low doses, but many of the drugs are as effective or even more effective at low doses. The second misconception is that phase 1 drugs are toxic. And this is an absolute misconception. The death rate in cancer trials related to the drugs is less than 1 in 200 patients. And considering that these are often very advanced cancer patients, this is an extraordinarily low death rate. And then the final misconception is that phase 1 studies should only be used to determine toxicities as they have little efficacy. Again, maybe this was true 20 years ago. This is absolutely not correct anymore. And it's very apparent that even patients with advanced end-stage disease, as well as cancers without effective therapies, can respond to appropriately targeted phase 1 treatment. And I can give you lots of examples, but I'm going to give you an example. And we did this study about a decade ago. So this is not really just happened yesterday, where these phase 1 drugs were working well. This is a drug called XL184. We did the phase 1 trials. It was a first in human, never been in human beings before, RET and VEGFR inhibitor. And this is in medullary thyroid cancer. It's a waterfall plot. Everything below the horizontal line, all that orange that you see, are responders. So you can see that the vast majority of patients responded. And this drug then is now called cabozantinib and was approved for this indication. So really quite remarkable responses, even in phase 1. And this was done by matching the patients to what the activity of the drug showed. Furthermore, the FDA has now approved drugs after phase 1. If you had asked me 20 years ago if the FDA would approve drugs after phase 1, I would have said, no, I don't think that's going to happen. But with our modern drugs that we really have a lot of knowledge about, this has now happened. And here are 2 examples. Ceritinib, which is an ALK inhibitor, very effective for lung cancer, was approved after phase 1. The headline was "Ceritinib runs the 3-minute mile." And another drug, pembrolizumab, was first approved for melanoma after a phase 1 trial. So let me get into what has been happening and lead you through the, let's say, last 15 years of development in early clinical trials and precision medicine. And so I'm going to start with MD Anderson around 2007, where we started doing our first generation studies with sequencing. This was very primitive sequencing compared to the powerful technology that we have in the clinic now, but it gave us our first glimpse of the power of matching patients to the right drugs. And we started a master protocol called Profile Related Evidence Determining Individualized Cancer Therapy, or PREDICT. We have the same protocol at UCSD. And the idea was that everybody that coming into the department could fit on that protocol. We wanted to eliminate the problem of strict eligibility that a lot of protocols have. And this protocol included patients with any type of cancer and any type of genomic alterations. And the idea was to match patients with the appropriate drugs. So this is what happened. All these patients were referred to phase 1 departments. So they had a variety of different cancers, but by definition, by being referred to our department, this meant that they had an incurable metastatic disease and that their tumors had failed to respond to 4 or 5 prior therapies on average, a tough group of patients. And remember, again, this is first generation technology with genomics. And this is, again, a waterfall plot. Remember, everything below the horizontal line is a response. Above the horizontal line, it's progression. So if you indiscriminately give patients phase 1 drugs that have and the patients have metastatic tumors that have failed approved therapies, the response rates are about 5%, not very high. But even with first generation technology, once we started matching patients to drugs, we saw much higher response rates. And you can see this visually. So this began to give us a glimpse of what the power of this technology was to be able to match patients based on their genomics in their tumor to the right drugs. But it also told us a lot more, and we began to understand that cancer was about to be reclassified, not just on the basis of this organ of origin, but on the basis of the genomic abnormalities. And this is just one example where we looked at HER2 positivity or ERB2 amplification in almost 38,000 patients. And everybody knows about this from breast cancer, where you have patients are HER2 positive and they receive targeted drugs. But it turns out that this alteration is present not just in breast cancer, it's also approved in gastric and stomach cancers, but it's even more frequent in bladder cancers, as an example. And there's a subset of colorectal patients that have this alterations. And then in salivary duct tumors, almost all patients have alterations in HER2. And furthermore, we now know through clinical trials that patients with all these different types of cancer, including colorectal cancer, if they have an alteration in this gene, just like breast cancers, they respond to HER2 targeted therapy. So this began to tell us that the molecular aberrations do not segregate well by organ of origin. And furthermore, that therapies could be effective regardless of organ of origin based on the genomic abnormalities. So what has been happening? So classically, we diagnose patients based on the organ of origin. We look at the surface of the cell and we say, oh, this comes from the colon, this is a colorectal cancer. This comes from the breast, it's a breast cancer. It comes from the lung, it's a lung cancer. This is on the basis of the light microscope, an instrument invented in 1590. And it's been a phenomenal instrument for over 400 years. And it's still the basis of how we diagnose cancer. However, more recently, we are now able to add something really powerful to this. And this is what I call the molecular microscope. It's not really a microscope, it's next generation sequencing. This allows us to not just look at the surface of the cell and say where it came from, but look deep into the cell and understand what is wrong with that cell that made it be a cancer. And then the next step from that is, now that we know what is wrong, can we target that abnormality? And we have gone, a next generation sequencing or NGS is now an FDA approved diagnostic. So this has really moved quickly. And just to show you how fast this has moved, in the 1990s, people said that the human genome would never be sequenced. Absolutely never. It was impossible. Well, that was over by 2003. The first human genome was sequenced. It took 13 years to be sequenced. Today, we can sequence a genome in a day. The first human genome took $2.7 billion to sequence. When we started our program at MD Anderson in 2007, it was $100 million for a genome. That was too much for our research budget and way too much for insurance. But today it's about $1,000, the charge often being $5,000 to sequence a human genome. And this has now brought this powerful technology into the clinic. This is breathtaking progress that I think is almost unparalleled in human history. So this has fueled this new technology, evolution in clinical trial design. And this is the type of evolution that we're seeing. We used to think lung cancer or colorectal cancer was one disease, but now we realize that lung cancer, and the same is true for colorectal or breast or take any cancer, is actually made up of many different diseases. And those diseases are defined by their genomic abnormality. In lung cancer, does it have an EGFR alteration, BRAF, KRAS, and so forth? But then the next step is that we realize that the same genomic abnormality, and I mentioned this before, can be found in many different tumors. So you may have the same genomic abnormality in colon cancer, in liver cancer, in a brain tumor, and in lung cancer, and that they all may be able to be treated with the same drugs. And so this has moved us from our gold standard traditional trials, which were large randomized trials where we did not select patients and only a few patients responded. And now a new model into small trials where patients are very highly selected to match them to the drugs. And when we expect a large majority of patients or a much bigger proportion of patients to respond. So these are some examples of genomically driven FDA approvals. These are just the examples for 2018. Every year, the number of uh, examples really expands very quickly. And so this is the start, but it's really gone beyond that. And it's really been transformative. And so the next step, it has been a new era where we have tissue agnostic approvals driven by genomics. Tissue agnostic means that the approval is for all solid tumors. It doesn't matter if you have colon cancer or lung cancer or breast cancer. If you have the genomic abnormality, you get the FDA approval. The first and breakthrough was for pembrolizumab, which is an immunotherapy for solid tumors based on microsatellite instability, where the response rates are about 45%. This was on May 23rd, 2017, and it broke the glass. It was a first tissue agnostic approval, was for all solid tumors. Number two, it was an approval based on a genomic marker, and that was mismatch repair gene defect or microsatellite instability. And then number three, there was a third part of this approval that had never happened before, but was very important, maybe even the most important part. And this is what most people don't realize. The approval was based in part on retrospective real world data. So it was the first time, to my knowledge, in cancer that the FDA allowed us to use the power of real world data without requiring completely a prospective trial. And since then, there have been other trials. This was done in part on real world data, but there have been other trials where the approval is in total on real world data. And of course, this allows tremendous speed for approvals. But there's more. We're not done. So that was the first approval that was tissue agnostic. The second is larotrectinib for NTRK fusion, adult and children with solid tumors in 2018. The third was another NTRK inhibitor for adults and children with solid tumors. And so it doesn't matter if you have colon cancer or breast or lung, the approval is for any tumor that has this alteration. And then the most recent one in June of this year is again for pembrolizumab, but this time, which is a checkpoint inhibitor for tumor mutational burden high patients that have solid tumors. And so I think this trend is moving very quickly. Approvals based on genomics, either within a specific organ or across all solid tumors. So now I want to talk about a little bit an area that I think is very important, and that's the marriage between genomics and immunotherapy. Um, to me, the pillars of precision or personalized medicine are genomics and immunotherapy. And although people think about these separately, to me, they're a couple and they're married to each other. And this is, I think, very important to realize. So, how are they married to each other? What is the bridge? The immune system responds to the mutations in a tumor. That's how the immune system recognizes that the tumor is abnormal. And that is why genomic alterations, specific genomic alterations like PDL1 amplification, microsatellite instability, and others, predict response to immunotherapy. So you can use genomics to choose the right patients for immunotherapy. And this is just an example. The more mutated the tumor, the better the response to immunotherapy. A few short years ago, patients who had highly mutated tumors, we used to hang our head and feel sad for these patients because the tumors were so messed up that we thought there would never be a way to treat these tumors. And now, through immunotherapy, these tumors have gone from being the worst tumors to being the best tumors. And the more mutations a tumor has, the more messed up it is, the better the response to immunotherapy. So if you have a low mutational burden, the response to immunotherapy may be 4%. But if you have a very high mutational burden, the response to immunotherapy may be almost 70%. And some of these patients appear to be cured, even of very advanced disease. So why is this? This is because of the way immunotherapy works. The way immunotherapy works is because in order to survive, the tumor has put the immune system to sleep. And immunotherapy can wake up the immune system. But once the immune system is awake, it has to recognize the tumor and know that it's different. That's its normal job. If the tumor is too close in appearance to a normal cell, even a awake immune system may not be able to recognize that it's a tumor because the immune system was never set up to attack normal tissue because that would be very dangerous. But if the tumor is completely messed up and has multiple mutations, as soon as our immunotherapy wakes up the immune system, um, the immune system recognizes this messed up cell and immediately gets rid of it. And that's why we have so much hype about immunotherapy because these patients with high mutational burden can do extremely well. And by the way, they do well regardless of whether they have microsatellite instability high or they have high mutational burden for another reason. So this is our precision medicine clinic. We start with what everybody else starts with, and we look under the light microscope and decide what the cancer type is. Is it colon cancer or lung cancer and so forth? But then we go and every patient has a very intensive genomic screening, protein analysis, immune analysis, and blood tests for genomics as well. And then we match the therapy based on the genomic profile. So, and we present the patients at a molecular tumor board where we bring together physicians of various specialties and our scientists. And the idea is to give treatment recommendations. This is not just a research molecular tumor board. Of course, we do research, but the idea is these are recommendations that will be carried out in our patients. And altogether, we have a lot of experience. We've done molecular profiling of some type at UCSD in about 21,000 patients. So I'm going to give you some examples of what we do and with different tumor types. And then I'm going to walk you into our master protocol. So this is a patient with a metastatic basal cell carcinoma. And I actually saw him in clinic last Friday, which will give you a hint that he did well. So he was a 55-year-old man. He failed multiple treatments. He failed all the approved FDA therapies, failed 6 treatments when I saw him. Next stop looked like it was hospice. And he also failed the targeted therapy to the abnormality that is typical for this disease. And he had metastases to the liver, bones, and brain, was not in good shape at all. And then question, this is what we ask for physicians. What's the next step for this patient? Hospice, next generation sequencing, enroll on a clinical trial, or chemotherapy, another chemotherapy. Well, the right answer may be hospice, but we decided to do a different answer and do next generation sequencing, and then based on that, enroll him on our master protocol. And so this is what we found when we did next generation sequencing. He had multiple alterations. He had a complicated tumor. He did have the alteration, patch 1, which is the target of the FDA approved therapy, vismodegib or sunitinib. But now you can see why he didn't respond. He had so many other alterations. So just targeting this one just wasn't good enough. But what he did have is he had a very high tumor mutational burden. Anything over 20 is high, and anything over 50 is very high. And then he had another feature that is sometimes a feature for predicting response, is called PD-L1 amplification. So we decided to give him immunotherapy. And we treated him with a drug called nivolumab or Optivo. This was, as an example, of his liver metastases before. This was at 2 months. And as I said, I saw him, we treated him in October 2015. I saw him in clinic yesterday. He is clear of disease now at 5.5 years. So this is why people get excited about immunotherapy, because there are some responses that are extremely dramatic. I do want to say, though, that it's not all good. There's also patients who do very badly with immunotherapy. It's almost like you pour gasoline on a fire. They're called hyperprogressors, and they get worse, sometimes very rapidly with immunotherapy. And this is an example of such a patient. This is a breast cancer patient. This is her tumor 2 months before immunotherapy. This is one immediately before immunotherapy, and then she gets immunotherapy, and within 6 weeks her tumor explodes. And but what is important here is, in our analysis, we have seen that there are 2 genomic alterations. One is an EGFR, and one is something called MDM2 amplification, that predict for this resistance or even accelerated progression after immunotherapy. So the bottom line is that next generation sequencing can help define not only who to treat, but who not to treat. And that is just as important. So going back, I'm going to give you another example of very sophisticated technology and what it can do for us. This was a 49-year-old woman that I saw in January 2016. And so that is now 5 years ago. And she came from Saudi Arabia, and she had a cervical high-grade neuroendocrine tumor. She had surgery, radiation therapy, and chemotherapy. And unfortunately, she came to us very late. She had a very large abdominal tumor. Her bowels were obstructed. Her kidney was obstructed. She was not in good shape. And again, what do you do next? Maybe the right answer is sent to hospice, but we actually decided, especially because she came from so far away, that we would try to sequence her. and see what we could find. But we had a big problem. She probably only had a week or 10 days to live because her bowels were obstructed, her kidney was obstructed. And so we didn't have time to do a biopsy. So what we did is we used a new technology. We now have experience with almost 6,000 patients, but this is a liquid biopsy. It's just taking a blood sample and doing the sequencing of the shed DNA from the tumor on that blood sample. And of course, that can be done very quickly. And what we found when we did her blood sample is that she had a lot of mutations in the blood. Most people have 3 or 4 mutations in the blood. She had about 20. So we took a guess and we thought she has a high mutational burden. We will try the immunotherapy with her. And that's what we did. We gave her a checkpoint inhibitor, nivolumab, and this is her tumor before, this is her tumor after. And at 3.5 years, she was in complete remission. It's now 5 years. She went back to Saudi Arabia, so I haven't heard from her. But as far as I know, she's still doing well. And then we did the tissue sequencing, and it confirmed that the blood was giving us the right information. She had a lot of mutations on the tissue. Usually we see 4 or 5. She had a high mutational burden, and it turned out she was microsatellite unstable, and she had a gene defect and mismatch repair gene. And now we routinely can do blood tests and measure the tumor mutational burden and microsatellite stability just on a blood test. These have become routine tests. So important point, cutting edge technologies are needed for complicated cancers, and blood-based mutational burden and microsatellite status is now available. But now let's move on to the next step. And that's like the future, which is here. What if every patient with metastatic disease is different? I compared them to snowflakes. And this is an example from some of our tumors with metastatic colorectal cancer. And what you can see is that each tumor, they don't have one alteration, they have multiple alterations. And even when they have alterations in common, the rest of their molecular portfolio is different. So does it really make sense to give these patients the same drugs? To me, it doesn't. They should get one of the same drugs because they both have KRAS as an example, but the rest of the portfolio is different. So we need to individualize the drugs, and that's not something that we've done in the past. So we set out to do that. And instead of using a consistent drug between patients, even the presence of different molecular profiles, that's the old way, we used a consistent strategy, which was molecular matching, but allowed each patient to get different drugs. In other words, if patients had A, B, and C alteration, and the second patient had A, E, and F, they didn't go on the same set of drugs. They went on a set of drugs that was customized to them. So instead of the drugs being the center of the universe, the patient became the center of the universe. And instead of fitting the patient to the trial, we fit the drugs to the patient. And we created a trial to do this. It's called the iPredict trial. And we started in February 2015. And the idea was to do customized combinations of drugs. And the second idea was to bring it earlier in the course of the disease. The trial was published, the first part of it was published in Nature Medicine in April 2019. I'll review what we did. Patients with solid tumors had molecular profiling. They were discussed at our molecular tumor board. The physician determined the treatment plan. So the physician was free to follow the molecular tumor board or to ignore it. And then we looked at how well were the patients matched, and we scored that. And if more than 50% of markers were targeted, that was high matching, and low matching was less than 50%. of markers targeting. So this is really important. We didn't just say whether a patient was matched or not matched. We want to look at the degree of matching, how many, what percentages of the molecular alterations we were targeting. And I'm going to give you this example of a table to think about. If a table has one leg, and that's equivalent to cancer that has one mutation, if you hit that one leg, you may collapse it. On another hand, if a table has 5 legs, which is like a cancer that has 5 alterations, you can only collapse it depending on which alterations you hit and where they sit. So if you hit that center alteration, you're not going to do anything. That table stands. And if you hit 4 of the peripheral alterations, you're still not going to do anything because that table's still going to stand. Effectively, you have to hit all the alterations in this case. And then there's all sorts of different tables, just like there's all sorts of different tumors. And in some cases, you may have to hit all the alterations. And in some cases, you may just have to hit specific alterations that are strategically placed in order to collapse the table. And the same is true with tumors. So next generation sequencing is needed to understand how to disable cancers with customized combination therapies. And we customize for each patient. And the conclusion that I'm going to show you is that not all therapy matches are created equal. So this is the results of the study that we published. And if patients were highly matched, which is more than 50% of the alterations were hit, this was the response rate. Remember, again, these are difficult patients that have been, their tumors have failed multiple therapies and before they come to us. If the patient had a low match, that doesn't mean they were unmatched. Some of them were unmatched, but some of them were matched, but only with a low matching score. Their response rates, they existed, but much lower response rates. And then look at the survival. For patients with low match at 2 years, the survival was about 23%. For patients with high matches, the survival was much higher, about 65%. And now I want to give you some examples of the way we individualize therapy. So this is a patient with a cancer, a 62-year-old man with a cancer of unknown primary. Means we don't know where the cancer came from. And he had a KRAS mutation, which we treated with a MEK inhibitor, trametinib, and he had an ARID1A alteration, which can be targeted with different drugs, but we chose a PARP inhibitor, olaparib. You can see his beautiful response, and he has therapy ongoing at 15 months, tolerating the therapy well. This is our results in metastatic colorectal cancer. We've just submitted the paper looking at matched versus unmatched therapy for progression-free survival. And you can see there's a statistically significant improvement in progression-free survival when we match the patients. And then I want to give you just some examples of how we do this. This is a 41-year-old woman with metastatic colorectal cancer. She had already, her tumor had failed to respond to several therapies, which you can see in the treatment history. And this was the next generation sequencing we did, both from the tissue and from the ctDNA being from the blood. And this is how we matched her. APC is a gene that's hard to match, but there's a drug that's called Sulindac that can be used, a pain medication. P53 is considered undruggable, but we actually consider it druggable. It can increase the blood vessel supply to the tumor. And we give a drug called bevacizumab, which decreases blood vessel supply to the tumor. Not that this is a perfect drug for P53, but we have strong evidence that it does have activity. And then a patient had a KRAS mutation, we gave a MEK inhibitor. So this is entirely a customized combination based on genomics after the patient had failed multiple therapies. And here you can see the treatment tumors before and after. The before is on the left-hand side and the right-hand side is after. 9 months after, you can see that the patient has had a really excellent partial remission on this combination. And this partial remission, the progression-free survival is ongoing at 18 months. This is what happened to the CEA. You can see the abrupt drop in the CEA with the customized precision combination. And we also looked at the blood to see what was happening to molecular alterations when we targeted them. And not surprisingly, the molecular alterations that we targeted were disappearing from the blood. Here's another patient, a 53-year-old woman with metastatic colorectal cancer. And this is sort of, to me, a really fascinating patient. In the tissue, she did not have any EGFR. But in the blood, ctDNA, she had an EGFR amplification. And EGFR can be targeted by several drugs, including drugs that are FDA approved for colorectal cancer, but are not usually used as single agents. So we gave her one of these drugs, cetuximab, which is an EGFR antibody and very commonly used for colorectal cancer. And you can see that her tumors have dramatically shrunk in the liver from the left side to the right side, just on this single agent matched to an abnormality that we found in her blood. And here's another patient. I know there's a rumor that microsatellite stable colorectal cancers don't respond to immunotherapy. And for the most part, that rumor is probably true, but it's not always true. And here's an example of a patient. So this patient is a 62-year-old woman with metastatic rectal cancer, and she has what I call a high intermediate tumor mutational burden. She had 18 mutations per megabase. So pembrolizumab is now approved. We treated her before pembrolizumab was approved, but she had 18 mutations per megabase, which we consider 20 or more high, and the FDA cutoff for approval is actually 10. Microsatellite stable, and what you can see in the PET scan on the left with the bright lesions versus the right is the tremendous improvement in her metastatic rectal cancer just on pembrolizumab. And she is now 24 months, 2 years, and has no active metabolic disease at 24 months. So I just want to mention a few other things that I'm involved with that I think will help whose aim is to bring the precision medicine, personalized medicine clinical trials forward. I serve as the Chief Medical Officer for the Worldwide Innovative Network for Personalized Cancer Therapy, which is an international global delivery of precision medicine being the objective. And the idea is to look beyond genomics, which is just the tip of the iceberg, but to look at transcriptomics, proteomics, and epigenomic changes. And transcriptomics is the RNA, how the genome is translated into RNA. This has been more difficult to look at technically, but we've actually done a study that looks at both genomics and transcriptomics. This was published in Nature Medicine, April 2019. First precision medicine trial in solid tumors that looked at transcriptomics, and we found that it could be effectively used along with genomics in order to navigate patients to clinical trials. And we're also about to start, or starting, a new master observational trial type that is a registry for oncology outcomes across the country. And we published an overview of what the intention here to collect data across the country for the benefit of patients. And then I just want to finish by saying we've talked a lot about the tumor, but less about the host, the patient. And I think this is an area that we have not done enough work in, and maybe the whole scientific community hasn't done enough work in. So the patient, the innate genomics of the patient, the microenvironment influences what happens. And this is a real person. And, you know, the question is, she's sort of in your face. She's a chain smoker. She just had her 100th birthday and looks pretty robust and has an attitude. And so, you know, is this good luck or is this genomics? And I don't know the answer, but I'm willing to bet it's genomics. That this is her genetics. And so genetics, in my view, can influence everything. And I want to stop here and give special thanks to the great team of people we have, and then the really special thanks to our patients. And I'm happy to entertain questions, so thank you.
Thank you, Dr. Kurzrock. That was amazing. That was wonderful. So I think we have one patient. I'll see if she has any questions. Amrit, if you want to ask something, you're free to ask now.
Yeah, I'll post my questions because I have quite a few.
Yeah. Okay. So then I will start with some questions, and then meanwhile you can post them in chat, and then I can read them. So, Dr. Kurzrock, you talked about real world data and how you know, certain approvals are based on part real world data, and you know, that there are now more studies that are looking at real world data. Can you tell us more about it?
Yeah, so we now have the ability to do things that, again, you know, I talked about the genomic ability to do things that we couldn't imagine 20 years ago, but we also have the ability to look at data in ways we couldn't imagine 20 years ago. So we have, for instance, computerized charts on millions of people. And that's real world data. And it can tell us how patients do, and extraordinarily powerful data. And sometimes people say, well, that's not as good as a clinical trial, but I'm not sure that's true. I'm going to give an unpopular opinion. I think it may be even better than a clinical trial because there's no eligibility criteria. It's real world people with all their illnesses. Anybody who's tried to get into a clinical trial knows, you know, you may not get in because you're sick or you have heart disease or something. But real world data, this computerized data, is enormously, enormously powerful. And I'm just going to give you an example that's not actually cancer, but it's about COVID. So, you know, everybody pretty much well knows that if you lose your sense of smell or taste, it's a symptom of COVID. But I'm not sure everybody knows how we figured that out. And the way we figured that out is somebody created some online app where people could say what their symptoms of COVID were. And then whether they had had a positive test or not. And that app was populated with a few 100,000 people answering in just a few weeks. And when that data was analyzed, what was in common between the patients that ended up with a positive COVID test, that they self-populated this real world data, was they lost their taste and smell. And that's where that data comes from. So it's just a small example, but we now have but it's an incredible example. You know, you put something out on the internet, people answer the questions, and in a few weeks you have hundreds of thousands of answers, and you have a computer that looks at it and comes out with the symptoms that are indicative that you have COVID. So the same thing can be applied to treatment strategies, to symptoms, to indicators of disease, and that's what real world data is about.
Okay, thank you very much. That was a very illustrative example. So now I'm going to read some of the questions that Amrit had posted. So the first one is, he says, you mentioned that UCSD has a personalized medicine department. Do you utilize third-party companies like Foundation One to determine targets, or do you do things in-house?
The answer is we do both. So UCSD has a nice 397 gene next generation sequencing assay, but we also send out, and I'm a very strong proponent of that the doctor can choose which assay they want to do. So the most common assays used are by our doctors are Foundation Medicine, Tempus, and Guardant, but our doctors also use Caris and Paradigm and many other vendors. The vendors are cleared through a project manager who makes sure that they're appropriately licensed. They have to be CLIA, and in California, they have to have a special licensure as well. But the doctor gets to choose which vendor he or she thinks is best suited for the needs of that patient. And they may use the UCSD lab, or they may use outside vendors that are appropriately licensed.
Okay, thank you very much. And then the next question, I think I'll club a few questions together. So next one is like, many patients get their NGS done on their primary tumor. How different are the metastatic tumors versus that? The next question is the same about TMB, whether the primary and metastatic, when you look at the TMB, is it that different?
Yeah, so the answers may not be the same. So the primary and the metastatic is well published by many groups, and we find the same. The primary and the metastatic have overlap, a lot of overlap, but they are absolutely not the same. And that is known as tumor heterogeneity. And you can biopsy the metastatic tumors, especially if there's one that's resistant, to see what may be driving that resistance. Like, let's say the lung tumors are shrinking, but you have a tumor in the liver that's still growing. You might want to go in and biopsy that tumor in the liver and see what new genomic changes is driving the tumor in the liver, because the lung tumors are shrinking. The other thing that you can do is the liquid biopsy, and that's the blood-based biopsy. Those are a little bit less sensitive because it's actually incredible technology that you can take fine shed DNA and sequence it. But it's still a little less sensitive because it's still very small amount of DNAs, but it's still a very powerful technique. And the advantage over the tissue, and this is a very important advantage, is that the tissue, if I take a piece of the liver and I do the sequencing, I only know what's in that piece of the liver. I don't know what's in the lungs. I don't know what's in the bones. But when I take a blood sample, it will reflect shed DNA from everywhere. And so that's one of the advantages of the blood. And so again, the answer is, we know that the primary and metastatic tumors have a lot of overlap in their genomic portfolio and their immune portfolio. But we know that they have differences. Now, tumor mutational burden is another story. We have a paper that we've submitted. It's not published yet. But it suggests that tumor mutational burden is pretty stable at different time points, and with different biopsies. So again, this has not been yet peer reviewed. It's not published yet, but we feel confident in that data.
Okay. And then the next question is like, how many patients really benefit from targeted therapy in CRC?
How many patients? Well, that's a good question. I think it depends on, just like everything else,